Hey everybody, welcome to Tea Talk Tuesday. It's Stacy Sisto again, your host. I'm going to give everybody a minute here to start joining. One thing I did is I keep forgetting to tell you guys about my tea. So like literally my tea. So this week I put it in front of me so I wouldn't forget. So tonight is orange and cinnamon spice. I love cinnamon. I like orange too, but yeah, I don't know, something about cinnamon. I could put cinnamon in like almost anything and it's delicious. Especially if you drink coffee, if you put like whipped cream on the top and then some cinnamon on it, oh, it's delicious. So tonight's tea talk is actually about active condition versus history of or Z codes. And so we're going to dig into that and then also do the open talk, open tea talk. So Q&A can be about that topic or any topic of your choice. So if you have questions, just please make sure you post a comment so that I can try and answer your question. Of course, if you ask me something that I don't know off the top of my head that I can't answer tonight, I will research that and get back to you either in email if you provide that or in the next Tea Talk. We also have, just to remind everyone, an email address. So specific to Tea Talk, it's teatalk@stalkinghorsellc.com. So you can email your questions to that email address and we will answer them during Tea Talk or be able to respond to you, from that email. So as long as you also have any PHI, so protected health information removed, you can send in like an example note or a piece of documentation if you have a question or concern about it, and we'll take a look. So again, this is about building a community and helping providers by providing some free consulting during Tea Talk Tuesday. So make sure, again, you write down the Tea Talk at stalkinghorsellc.com. And if you haven't done so already, please make sure that you join the herd and you like and subscribe to our channel on YouTube. So right now we are broadcasting through YouTube, LinkedIn, and Facebook. But YouTube, in my opinion, is a really nice platform to view off of. And we may end up just going through YouTube here soon. I think it also eats up a lot of space when you try to push through multiple platforms. So by focusing on the one, I think it'd be easier to share content without having like a lag in the video. I'm still working on that. I'm not too good at remembering to stop talking. I have to like shut my mouth when I go to share a document because I don't realize that as I'm talking while the document is trying to load, it's either breaking up or you guys can't hear what I'm saying. So I have to get used to that too. So it's a learning process. So it looks like we have a couple people joined, and I'm going to go ahead and just dive in. Let's see here. Oh, we've got new. Hi, Francine from Florida. We get a lot of Florida people because we are in Florida. But we usually have some people too from some other states joining in. We've had Vegas. We've had Missouri, New York. So yeah, pretty good. Nice to see you guys again. Thanks for continuing to join. So let's jump into that active condition versus history of. So I think the first thing to say here is that from the provider perspective, there's really a what do I want to say? Like a language barrier, really, truly, between how you document as a doctor or a provider, right? Versus how those things get translated into the codes that we use to report on claims and for statistical reasons, right? So one of the biggest problems with understanding the difference between what we call these Z codes and history of codes and then an active condition is In the coding world, if a piece of documentation says something like, let's see, history of back pain, right? That in coding language means that back pain currently is not happening, that it's a past condition. Or if we said, history of colon cancer, right? That in coding language translates to this patient no longer has this condition. It's part of their past medical history. And so there's codes that begin with a Z, so we call them Z codes, that are reported for those active past medical histories. So over those history codes, there's Z codes for those. So, but in providers' language, and many that I've spoken to as far as where their training goes, a lot of them are taught to document by starting off talking about the patient in terms such as, I'll use myself. So Stacy Sisto is a 40-year-old female who has a medical history of, and then they list the litany of conditions. But what they typically mean there is they're saying that my current conditions include, and then whatever that might be, whatever, asthma, COPD, or diabetes, or maybe some form of cancer or heart failure, or whatever it might be. Their intention is usually to indicate that those are the conditions that they're involved with or going to be discussing. There's a separate section typically in the note that houses the past medical history. But it's not always that way. I mean, sometimes they do intend for it to be a history of. But it's important for providers to understand that when you say history of asthma or COPD or history of cancer, technically, again, from the coding end, it means that that condition is no longer active, that it's in the past, not current. So for clarity, the recommendation is that you don't use that history of language when you're referring to an active condition. And honestly, that makes it much easier for any coding or billing staff, or even makes it easier for you as the provider during an audit situation, because the more clear it is in both provider's language and in coding language, the better off you're going to be at the end in any kind of audit or review situation. So instead of saying with a medical history of, or even past medical history of, or current history of, just saying, so-and-so is a, let's say, 40-year-old female, current chronic conditions include, or current conditions include. And then by saying that, you're indicating that those conditions are indeed active, they're current. And that's super, super helpful. So some of the biggest conditions that are problematic with this active versus past medical history would be, I kind of named them, like cancer, atrial fibrillation is another one, COPD, diabetes, hypertension, and a lot of them that are technically inherently chronic and not necessarily something that you would see as acute. But again, it's just sort of a habit, I think, for providers to document in that way. So their notes are typically structured where there's a section for history of present illness. And usually that's where they use that language of, medical history of, and then they list whatever those conditions are. But then when it comes down to the assessment and plan section, most electronic medical records now that you document in require the provider to actually perform a search. So they require them to look for a code, specific code. So one thing as a provider to be super careful of is if you're using a Z code, it may be a code that's past medical history that's non-active, or it could be a status code. So just make sure you're paying close attention to what you're selecting if you're in that Z code section, and that your selection is accurate. So if a condition is truly active, so it's currently being treated and the patient is actively experiencing symptoms from it, or is being medicated for it to treat it, then you're good. Make sure you select that active code. But the cancer diagnosis can be tricky because there's some cancers, such as breast cancer and prostate cancer, that there can be treatments involved that are, longer term, or there can be medications that are used as a preventative measure, especially with breast cancer. So you have to really be clear about why a medication is being used or what the active treatment is. So if it's a medication that's being prescribed to prevent reoccurrence, so it's a preventative measure, then that would not indicate an active cancer, right? So it would just be preventing a recurrence. So we have to be careful about that. And they're getting a little bit more picky as the years go on about what that documentation should look like. There's a resource, the Coding Clinic. I kind of like, it's a love-hate relationship with the Coding Clinic, because the Coding Clinic has great information and it's recognized professionally. It's a credible source, but it is extremely expensive. And so unless you're part of a large organization that has funding to be able to afford the access to it and unlimited access, it is very expensive and difficult. So smaller provider practices or auditing firms or just individual coders, really it's difficult to afford, really. And that has actually been a challenge. I wish that information was more open and available to everyone, but it's not. But eventually, stuff does come out and more guidance. But the Coding Clinic usually comes out with some details first. They spill the tea first, usually about some of those more complicated coding scenarios. So one of them being, like, for example, AFib that I mentioned. So atrial fibrillation. So there is some procedures that can potentially correct it. So like cardioversion, for example. So you may have a patient that undergoes a procedure and then it potentially gets rid of the AFib, but the AFib can come back. They may have to be managed on other medications. So it's interesting because Coding Clinic actually had changed their mind a few times on different scenarios when you can or you can't, like when you have to use a past history code. Like if they had a cardioversion for a while there, they were dead set on, hey, it's past medical history. Then as more information came out within medicine, they were like, oh, hey, actually there's some exceptions here. These patients may have some breakthrough episodes, so on and so forth. So there is an opportunity here to use an active code in some scenarios. So again, Coding Clinic is really good for that too. So just knowing, like, with advancements in medicine and in data that we find, some of those guidelines can change here and there. So it looks like we had a couple more people join. That's great. So if a patient is being treated, again, actively for that condition, even if it's through medication to control it, just because it's controlled doesn't mean that it doesn't exist, right? So if you removed the medication, that condition may come back. So let's say it's in this case of AFib, right, that you have a patient on medication and so their rate is controlled, doesn't mean that they don't have AFib, because if you remove the medication, the treatment, it will come back. So again, that would be an example where, hey, they have active treatment here with this medication. So that's reporting this code as active, as a current active condition. So we also have, COPD is another one where a patient may be well controlled for a long period of time. But again, like, what's the treatment? Do they have treatment going on? And again, in that assessment and plan, like if you as the provider bring that condition down and you put that diagnosis in your assessment and plan, documenting that plan clearly is important and really helps to support and helps us to understand which code is most appropriate, what we're supposed to be selecting there. It helps us to make any corrections. So one of the biggest ones that I didn't mention yet, but it gets like a ton of attention when we're educating physicians, is stroke. So many times we'll see documentation from provider's office. So let's say patient goes in for an office visit and that they have had a stroke and they're following up. We will see the code sometimes for a stroke in the note and reported out for an office visit. But a stroke, when it's actually considered active, is when it's in that acute phase and when that treatment for it is happening. So that's really a code that is an inpatient code. So in order for you to accurately report that, the patient would be, they'd be having the stroke then, which then they would need to be hospitalized for, which you can't clearly make that diagnosis in the office because you need that testing to verify what was happening with the patient. So you may suspect a stroke. So, and but not be able to confirm that. So you'd be sending them to the ER immediately to get evaluated for that. Then as they're getting that treatment for the stroke, that stroke code is reported in the hospital through that period of time that they're receiving that acute treatment for it. And so we see a comment here from Lindsay, and she says, "Oh my word, yes." See this all the time with stroke diagnoses. And it's true. But what makes it confusing is that I can see from the provider's perspective, well, the patient's had a stroke. They're coming in, they're following up on it. I'm talking to them about whatever we need to follow up on from that, and the continuous treatment that they're going to need, or some more testing that we're going to put in place, preventative measures to not have another stroke, etc. So the key there is that when they're following up in your office from having a stroke, is there any after effects or residual deficits, as in coding language, what they call it, from the stroke. So are they having difficulty speaking, or difficulty moving, or anything like that, difficulty swallowing? Any issue from the stroke would be a residual deficit, and then that code should be applied, which is in a different section. It's similar code, but it's technically not an active stroke code. So it's just for the residual deficits. Now, if the patient really made a full recovery and they don't have any residual deficits, that's when you would use the Z code. Or it actually comes up as like personal history of TIA, so transient ischemic attack, but that's the code that you would use for a follow-up from a stroke with no residual deficits. So in the outpatient setting, so physician practice setting, we really shouldn't be seeing the active stroke code. It should be any residual deficits from the stroke that are being reported. And so again, there is a whole section of those, but we do see that quite often. And it's actually one of the codes if you're in risk adjustment, that many organizations started putting safeguards in their software to where if it's an outpatient setting, their system will like kick that code out and set it up for review. So I know plenty of large organizations, in particular Epic, that where they use Epic, that software is pretty good at being able to stop those claims from going out with that code on it so that a correction can be made and then the appropriate code applied. So they can kind of put some rules in place in the background to stop that from happening. But yeah, it's definitely one that occurs a lot. But in the risk adjustment world, that can have a huge impact, right? Because if you report a code as active that's supposed to be a history code, you're then claiming that that condition should be predicting cost for the patient for the next year. And then that code adds to what's called the risk adjustment factor or your weight value, and it impacts payment. So in that way, it's a risk. It's a compliance risk. It'd be the same as essentially like upcoding an E&M level or a CPT code, So it would be getting an increased payment because it's triggering an HCC that actually shouldn't be there in that particular case. Now, some of the residual deficits from a stroke actually do still risk adjust. So just as a heads up on that, if you're in here and you're working in risk adjustment. So yeah, that's interesting too. So you can take a look at that. And one of the best tools I think that's out there that's like not super, super expensive is actually AAPC's Codify. So you can get a reasonably priced subscription and they will actually show some information on HCCs if you're curious about that and looking at the stroke status and the residual deficits to see which ones actually risk adjust. So yeah, if again, kind of the rule of thumb is if that condition is active and being treated, try not to be using the terms history of in the documentation. And as far as the coding side is concerned, if you're reviewing documentation and you've got an HPI that, kind of has this history of everywhere, be paying attention to that assessment and plan and try to piece that together to make sure that it's clear. If it's not clear, I always recommend, sending a query to the provider to obtain clarity on that, because again, depending on how you're set up, some of these conditions can really affect payment in the long run, or an audit, right? So we don't want to report without the clarity being there. So it's also a great idea to send a query if needed. So yeah, I know our team again has kind of had some run-ins with that diagnosis in particular, and it's always a common theme in risk adjustment. And then for those chronic conditions, again, like COPD, diabetes, hypertension, I'll just list those for now. Those are conditions where I said they're inherently chronic, right? So we typically those are conditions that we expect someone to have lifelong. Now, in the new rules for evaluation and management, and even in diagnosis coding, the rule is that a condition is defined as chronic if it's expected to last at least 1 year or until the death of the patient. So either 1 year or a lifetime. So, but a diagnosis such as diabetes, normally once you have actually had the diagnosis of diabetes, that's a lifelong diagnosis. You may be able to control it well, may be able to get the A1C down and again, be very well controlled. Some people are even able to come off of medication and just control it with diet alone, but it still means that you have the condition. It's never expected to be a history of. So it's just, again, how is it being managed versus is it something that's going to go away? And so, yeah, I see. We love those queries, right? So, Lindsay, love those queries. Yeah, we sure do. And for those providers out there, trust me, we get it. Like sometimes it's like we just want to cringe to sometimes have to send those queries too. Like we get it, and I know it can be super difficult to sometimes actually communicate like what you're thinking or what you're trying to ask in the right way. To providers or the opposite, sometimes providers like, what the heck are you trying to tell me? So I know from our perspective, we always make ourselves available too for a call. So we've had to send a couple that are like, if you have any other questions, just please, pick up the phone and give me a call, or we can schedule a call to discuss this particular question here. And sometimes it does require that. Nothing wrong with having a quick chat to kind of clarify the context or the content of something. So, yeah, I know, Lindsay, I get it. Love those queries. So, anyhow, I think from active condition versus history of that pretty much sums it up. I don't see um, many questions in the chat just as far as that content's concerned. I did see one from Lainey here. It says, so if they're being treated for preventative measures, it would be billable, correct? So with that, there's always going to be a diagnosis code available for it, right? So, for example, if they're prescribing a medication to prevent breast cancer from recurring, coming back, that would be a history code, like a personal history of breast cancer, and then it kind of breaks down further. But that'd be where you'd use that personal history code, because if they're treating the patient with a medication to prevent something, it doesn't mean that condition is currently active, right? Because they're trying to prevent it. Or the difference then would be if they're using the medication to actively treat a cancer. So even if the patient's actually had the surgery, so in some cases of cancer, someone can go in and have it removed, and it may not require any additional treatment. But other times, there's going to be chemo, radiation, or drugs that are prescribed, other drugs that are prescribed to treat that cancer. So still in the what they call active phase of treatment. And so that's where you would use your cancer diagnosis code, which most of them start with a C. So they start, ironically, C cancer, but yeah, they start with a C for an active cancer code versus one of the Z personal history codes. So I hope that answers your question. Here's a great question. So we have Chantilly. Can you explain a bit on how to distinguish a cancer in remission diagnosis versus a history of cancer diagnosis? Well, I can do my best. That one does get tricky because it would really, again, depend on how that's documented. So working with the providers to make sure they know how to document that level of specificity is important, because there are certain types of cancer that as you're coding them, they ask about remission status. And it's most of the time, it's not that our providers are not wanting to give us that information. It's literally just that they don't know about the level of detail available in the code selections. So I would say that if your practice is having a particularly tough time with some of those in remission diagnoses and trying to distinguish between that, putting out some kind of newsletter or a quick education, something together for the providers to kind of understand, hey, here's the diagnoses for cancer that also include hey, remission status, like where are we in this phase for the patient. Most of the time, once they are, once they're aware that, hey, these options are available, you'll see that improvement within the documentation. But again, that's going to be another one where you probably in the beginning will have to query about because it's not always known. And again, it comes down to that language barrier between, clinically, how am I just, kind of going about my day and documenting this and how I've been trained versus like what's available in this technical coding language. So just trying to, bridge the gap in that language issue, kind of break that barrier. That's going to help to improve and make it easier, smoother coding. And you may have to develop like a query related to that specific cancer type and the options available to send off. And, most software systems now are pretty good about allowing you to save the query that you have, or some of them call them tasks, right? So being able to save a specific query or task that you've developed. But just make sure that you double check and that you're sending something that's compliant. So you never want to lead a provider into a specific code selection. So you want to ask the question and provide the options available, and get the information from them. So just don't be leading in the way that you ask the question. Don't lead to a specific answer. Just give the options for the provider. And usually it's great too to offer like an other. Is there something else? And then they must remember, especially on the outpatient side, that again, if this documentation isn't clear, they would need to addend it for that clarity to be there for proper coding. The inpatient side is another story because it's like an episode of care. So from the point the patient gets admitted to when they're discharged, there's several opportunities on the inpatient query side for them to actually capture that diagnosis appropriately. From the outpatient side, again, when we're talking about physician coding services, provider-based services, they need it's per data service. So they do need to go in and correct or addend that note for the appropriate code to be assigned for that individual data service. Because again, it's not for like a whole episode, right? It's each individual data service gets billed separately. So hopefully that helps, Chantilly. Feel free to ask again in the chat. Hi, Christy. I'm so glad you actually made it. I know you had mentioned that this was a topic you were interested in as well, so I'm super happy that you made it. So let's see what your question is here. So how would you decide which family history to document? I struggle with my secondary diagnoses a lot and still can't decide which ones to grab and which ones not to. That is a great question. So I think it depends on specialty and relevance to the particular encounter that you're dealing with. So the annual wellness side, that one's a big deal, right? So if it's in something like an annual wellness visit, and Christy, feel free to comment again, like if you're talking about a specific specialty or a specific visit type over another, but otherwise I'll just try to like break it down for each one. But basically, any like annual wellness that you are working with, you're going to try to report as many diagnoses as you see are applicable. Now, from like a reporting perspective, our softwares, just to kind of cover this, can limit sometimes the number of diagnosis codes that you're able to actually push out. So that's also something to be aware of, and that may change. Depending on, again, the software that you have, and then if you contact the vendor, and they can sometimes change some settings in there. So I've seen, obviously some visits with as little as one diagnosis that are reported. And I've seen upwards of 40 some odd diagnoses being reported for a single encounter, which is, I mean, that's crazy, right? Crazy number of diagnoses. But when you look at like your paper claim form, there's like technically 12 slots for diagnosis codes. Electronically, there's typically up to like 24 for one, but you can submit additional diagnoses with an additional CPT, like an extra, it's like a filler code for most carriers that you can use. It's, yeah, gosh, it can be different for each carrier. So if you're in risk adjustment, you'd want to make sure that you like double check which one is their dummy code, and make sure you're using that dummy CPT code to report another claim. It's like, to get those additional diagnoses. Oh yes, so Christy, I see here you said that somebody had actually 42 on one chart before. Yeah, I believe it. I don't know how long that visit took, but wow. Yeah. So annual wellness, typically, you're going to try to collect and report as many diagnoses that meet reporting criteria. So if it's affected or impacted care during that encounter, you should report it. And so again, annual wellness, you could see that there's a lot more that technically could affect or impact care, because during an annual physical or annual wellness, part of that is talking to the patient about all of their chronic conditions, and then any risk factors that they have, which is where your question comes into play, right? So family history could indicate that they have a risk factor. So if there's a family history of colon cancer, for example, patient may need to actually have some screenings performed sooner than a patient who doesn't have family history of colon cancer. So in those annual wellness visits, there's definitely a lot more that would actually impact that visit, that has the potential for you to be able to report it. So, but again, the idea is if a diagnosis impacts care during that encounter, you would report it. So in the idea that a patient's coming in, let's say for a follow-up visit, and it's specific to, let's say it's specific to COPD, right? It really may not be appropriate to be or needed to be pulling some of these diagnoses or for the provider to document all of these personal history conditions during that type of encounter, something that's focused more on one specific problem area or complaint. So again, the rule of thumb is like, just think about, what is actually impacting care. And that's part of the ICD-10 guidelines for reporting as well. So if you're going to, I see you say that you're studying for your CCS, but you're trying to cross-train on all of it. So that's awesome. And you'll find that guidance in the ICD-10 guidelines themselves. So it's actually going to just, reiterate, it's going to say what I'm telling you, that if it's affecting or impacting care during that encounter on the outpatient side, yes, you're going to report it. So asking yourself if it's applicable to that visit is really key to reporting it properly, honestly. And that's important also, again, like in risk adjustment too, that you're not over reporting, because technically if a condition is in, past medical history, right, we're not coding from, on the outpatient side, we're not coding from past medical history, right? We're not coding from an active problems list. It has to be impacting that current encounter. And so we always try to remind providers, bring items down, your diagnoses, your conditions that have impacted care during that visit, bring it into your assessment and plan. And I have to say, with that, I am so incredibly happy that they changed the E&M rules, right? So we used to be on this system of coding for office visits where, did you do this in your history? It's like check boxes, what level of exam did you do? Did you look at this? Did you look at that? And so it created this environment of having highly templated documentation. And honestly, that really was, I think, counterproductive in healthcare. Didn't really help patients, and certainly didn't help other providers. Like when we were sharing records, so if you had to see a specialist and your records were pushed over, it just became like this. Your medical record just became so voluminous, like so full of just junk. And some of it was just not even medically necessary. It was just there because providers thought, okay, well, this is what I have to do. And I mean, to a certain degree, some of it was, in my opinion, a little ridiculous with the old rules, and some of the requirements didn't really make sense. And they did recognize that, and so they've changed it now, where your history and your exam just need to be medically appropriate. So there's no more check boxes like, how many organ systems did you review? Did you do past medical history, social history, and family history? Like, that doesn't matter when it comes to leveling. It's, hey, did you document an appropriate history and exam for this patient for this encounter? And then the leveling is done based on the medical decision making, which actually is in the assessment and plan. So the heart and soul of the medical decision making is, hey, what did I diagnose this patient with? What's wrong with them? What do they have? And then what's the plan to take care of them for it? So, and then of course, ordering of tests, or if the provider reviewed any tests or documentation from outside of their practice, that plays a part too. But the heart and soul lives in that assessment and plan. So dedicating more time to ensuring that as a provider, you're documenting all of the conditions that impacted your care during that encounter is just paramount. It's going to help you with your E&M leveling and supporting the proper code, so that the true accurate code level that you've actually performed or provided to the patient, and capturing all of those diagnoses to make sure that on the back end, you're actually meeting your quality measures. And also, if you're in risk adjustment, that you're capturing those conditions that are really impacting the patient and that can impact their cost of care. All right, Christy. So it looks like I think I've helped you with that. So you say that makes sense. You were working on E&M and you were struggling with history and family of, and that's what you noticed. So yeah, it's that E&M section, it gets crazy. And I can tell you that when you're studying for one of these exams, it's the craziest thing with the evaluation and management side, because the coding is not, it's not as, I guess, black and white as some of the other areas. There's it's multi-steps that go into determining that level. And so I know a lot of people had said in the past too, coding won't be around forever because, these systems, they're going to just do it for them. And, again, that still hasn't happened. I mean, the systems can recommend codes, and they certainly do recommend evaluation and management codes, but they're oftentimes incorrect, because you really have to have a human interpreting what these different elements are to determine that E&M level of service. So, and I can remember myself, many, many, many years ago when I went to college to learn coding, I can remember asking the professor at the time, I was like, hey, how do you know if the history is problem focused, expanded problem focused, detailed, or comprehensive? How do I know that? How do I know if the exam, what level of exam it is and what level of medical decision making is? And it was so funny because when you sat for the test, there were so many, there's for the general coding test, so it's just referring to the CPC, for example, similar to the CCS, that there's so many different coding topics within that test, because it's a general certification that you're getting. So that exam is geared toward showing that you have proficiency in coding so that you understand it. So they have to ask you questions like from all sections of coding. And so on the test, they actually would give you at that time the level of history, the level of exam, and the level of medical decision making. And then you just had to understand like how to select the code. But then when you actually got into the real world and you were looking at documentation, yeah, you were like you could be like a deer in headlights if you hadn't thought through the other side of that. So, Christy, it's great that you're thinking through some of these things because oh my gosh, it's there is a difference between, studying and taking a test versus like the real life application of coding. So, for sure. And looks like you saying that risk adjustment is your next journey once you're done with your CCS. That's great. And I think that the CRC is definitely a great certification to go for, even for providers. So if there's any physicians or nurse practitioners or anything on the line, it's also great for providers to get. I've known a bunch that had gotten involved in risk adjustment and really wanted to understand it better. And so they ended up uh, studying and sitting and obtaining their CRC certification. The CRC from the AAPC, the one thing I would tell you though, if you are looking into getting that is I highly recommend the review book that they give, but also any practice tests that they offer, take them up on that, and also do some additional research through Medicare, like cms.gov, like literally like look up risk adjustment and just look into all the information that they provide on it. Because the way that that test is structured, I don't know if anybody remembers anybody in here today that knows anything about when they changed education over to Common Core, right? So it used to be like you're learning math and it would be like, Johnny has 3 apples and Megan has 2 apples. How many apples do they have? And then you're like, oh, okay, 3 plus 2 is, 5. And then when they switched over to Common Core, it was like, Johnny has 6 elephants and Megan has 2 giraffes. How many kangaroos went to the market? So that's sort of how the questions read when they switched over to Comic Core. It was so crazy. I can remember like a bunch of videos and memes and stuff coming out of that. It was just nuts. But that, in my opinion, is how the test is for the CRC, like how the questions were written and structured. Now they do revise the exam every year, so I'm hoping, fingers crossed, that they kind of improved on the formatting and the way that they asked the questions. But it was, in my opinion, very Common Core-ish. Like sometimes you were like, what are you asking me? And risk adjustment questions can be answered differently depending on the perspective that you're coming from. So what I mean is like if a specific question is being asked of a health plan. So if you work at a health plan, so you work at like Blue Cross or Cigna or Humana or whatever, and you ask a question, the answer for like the appropriate process might be one thing, right? But if you work in a provider's practice and that same question is asked and like, hey, what's the appropriate process for this? The answer could be different. So try to, when you're going through those questions, try to figure out from which perspective are they asking you the question. And if you get the practice exams and the study guide that they offer for the CRC, you should see some of that in there and you'll know exactly what I mean. So I do highly recommend all of them. And I recommend going through and doing all of the questions in the CRC study guide and just going through and doing them, over and over again, making sure you really understand those concepts. And then the same thing for the practice exams, just going through until you really know it well. And some of the things they put in there too that in my opinion aren't necessarily related. It is, but it isn't. But they ask a lot of questions about like 5-star, like so the stars ratings for insurance plans, which yes, kind of sort of has to do with risk adjustment because they use the data that's reported set benchmarks. You'll know what I mean as you get into it, but when they ask questions about, like, you know, 5-star stars programs, whatever, that may be a concept that is extremely foreign to you unless you've actually done some work in a health plan before. Otherwise, you may be like, I don't even know what the heck they're talking about. So that may be an area of study that you really have to look into. And there were a fair amount of questions. There was like a section on that. So again, they're kind of asking you questions on that exam that are from different perspectives. Like if you worked at the health plan, you'd know about the stars ratings and how that works, and quality measures, right? You'd know more about that. You do learn some about it on the physician side, but again, depending on your role, if you're a coder that or a physician that just is working like with the documentation and applying codes and everything, if you're not working on the quality measures program, you may not really know that much about it in order to answer those questions or really know where they're coming from with those. So yeah, that's super important. Make sure you get those study guides. And I do have to say, I do like AAPC study guides for the most part. I found them to come in handy. They actually contain some pretty good information, especially the one for the CPMA. So if you want to get into auditing, that one is super helpful. I really enjoyed that one. Kind of sound like a nerd when they're like, who enjoys reading through a study guide? But yeah, that one's actually pretty good. It has some nice resources in it too. And if you ever think about going into auditing, that's a really good study guide to get. So I think I've actually addressed all the questions in the Tea Talk. So I'm just going to give you guys the reminder here that if you have any questions, again, make sure feel free to reach out to teatalk@stalkinghorseLLC.com. You can also visit our website at stalkinghorseLLC.com. We did actually put out that Modifier 25 webinar, and it's free. It's both on our website on the products page. You could actually download it with some materials that are in there, like come to you as like a zip file. So you can download it and it is free. You just have to go through the process of like answering the questions so that it can get your email and everything and then send you the zip file. So if you want to be able to share it or just have it on your computer to view it anytime, so you want to be able to download it, then I highly recommend going to our website, go to the products page. You'll see the one for Modifier 25. You'll see there's a $0 there. You can download it and you'll get the zip file to download and with the additional resources that come with it. Now, if you don't care to download it, right here on our YouTube channel, you'll see it under our videos. There's a webinar for Modifier 25. But then on our website, there are some additional ones. There's a webinar on the G2211, hot topic for that visit complexity that they started paying the code starting January 1st. And then also for the social determinants of health risk assessments, Medicare is going to start paying for those risk assessments come July. So again, now's the time to start implementing a process in your practice. If you may be performing risk assessments for that, which the two biggest specialties would be primary care and behavioral health, really are going to be impacted by those social determinants of health risk assessment. So I highly recommend for those specialties that you take a look at that webinar. Yep. And let me just double check here, see if there's any other questions. Oh yeah. Okay. Yeah. We love auditing, right? So yep. You love auditing. And Lindsay, I know you love auditing too. It's pretty cool. It gives you a nice break too breaks up the monotony of like everyday coding if you're able to get into some auditing, even if you just do it here and there. Yeah, it gives you a little bit of a different flavor, but yeah, typing out the explanations is always the interesting part. It's the critical thinking part of it. So thank you guys so much for joining Tea Talk. I hope that you enjoyed this episode. And again, don't forget to reach out with any questions that you have. Email us or join the next Tea Talk and feel free to ask. And so just remember, you heard it straight from the horse's mouth. Thank you guys so much. And I look forward to seeing you guys next time.